Thank you very much, everybody, for joining one more session of Oncology Beyond the Obvious. And we are very happy to see that there are several other organizations and people who are also, emulating us and starting genuine discussion about what happens in the real. And some of them are also showing what is their length and breadth of their evaluation and reach. So I thought, let me start with this. This is the OBT of reach among the various countries. And this represents that people from 44 different countries have either participated live or have watched our recordings that have been posted on YouTube. I think we are very satisfied and happy with this situation. Next slide. And then I take you back memory lane. Can you show the next slide, please? Yeah. So this is the OBTO that happened 4 years ago in November 2002. And that was also on immunotherapy. And we were really happy to see that so many people participated in the survey before that. And we also did a survey this time to see what is the real world scenario now that immunotherapy has been used by most of us. Next slide. And it was a little shocking to see what was the result. I don't want to go into the details, but from the pie chart, you can see clearly that people are divided between yes, no, and maybe. And I think, therefore, this OBTO becomes extremely important. And the topic that we have selected is on the real world status and data on immuno-oncology. So, with this little introduction about what has happened and why this topic is important, I will move on to introducing my co-director, Dr. Amish Vora. He is going to be taking these proceedings forward, and he will have the interview process going on, and he will introduce the person with whom he is going to be asking the question. So thank you, Amish. Over to you, please.
Thank you. So, Kavina Creations, yes. So, in my slides, there are a lot of next, I would say. So, please continue doing that. So, the topic, the discussion, first of all, I also wanted to share that I had invited some of the physicians in South Delhi. I had shared my link because there are many times a lot of questions about immunotherapy keeps coming in the CMEs which we organize. So I've invited, in fact, some people like Dr. Sushil Chauhan, who himself is running every Wednesday. There is a CME for last 20 years, which he's running for physicians, and it's called Physician Forum of India, and it's amazing platform to learn. With that small introduction, I'll come back to today's topic and discussion: real world evidence of immunotherapy induced IRAE. Next slide, please. And for this, we have selected this particular paper. Now, there can be a lot of discussion about why this paper was selected, but this is the paper where I felt the numbers are quite intriguing, and some of the findings which were there, which sort of hassled me that this is exactly not something which we see in day-to-day life. So we thought that we will scratch heads of our interviewees. Next slide, please. So why was this paper selected? That we all know the incidence of IRAs, but do we really know which patients particularly will develop IRA more than others? Which drugs cause more IRAs? Which cancer cause more IRAs? Which cancer subsite? Is it breast? Is it lung? Is it colon? Is it pancreas? We really don't know. Comorbidities, yes, we know, we have some fair ideas about that. And the most important is there, will paper like this help us to develop an algorithm which can predict IRAE in a particular patient? Is a question which I have. Next slide, please. So this particular study, it was drawn from One Florida Plus company, where they went through 4.7 million patients database in the North America, out of which they took out. Can you click next 3 times? Next, please. Yeah. So they took out 16,936 patients who had undergone ICI treatment, out of which 7,743 were excluded because there were some pre-existing immune-related conditions. So eligible patients were 9,193 patients. Now, out of this, they also further selected patients who had completed 1 year of ICI treatment because that was their cutoff. They wanted to see IRAE at 1 year, especially the patients who did not develop any side effects. So the final analysis included 6,526 patients. Next slide, please. Out of which 56.2% patients developed some form of IRAE. Next, please. Yes, so this is something which I wanted to show that in patient characteristics, how they have divided that. The column which I have highlighted is patients who did not develop any side effects. And the next column is patients who develop side effect. And the third column is hospitalized IRAE. We will come to results very quickly. Next slide, please. And next. So this is the comorbidity where if the patient has these many comorbidities, they have still not developed any IRA or they have developed IRA. Next slide, please. And next slide, please. And this was the cancer subtype. Now, this was something which was very interesting. And the most interesting part, which I didn't know, honestly. Next slide, please. There's a multi-site, if I have understood correctly, and I have read the paper 4 5 times, that these were the statisticians who have done the statistics. So multi-site, it means that more than one organ involved. So it's a metastatic cancer and nothing else. Next slide, please. This was interesting again. Next slide, please. So here, if they what they have said, see, we know the combination gives rise to more IRA, but here they found that PD1 has certain less IRAs compared to PDL1. But the most important part was if within the 30 days of starting immunotherapy, if you have given some form of chemotherapy, then immune related adverse events drop down significantly. Next slide, please. And the next one. No, previous one, please. Okay. So the point was this particular chart where if you see on the left hand side, there is a ref is written everywhere. So what they have calculated is they have taken one particular reference and the next factor they have taken as the whether this particular cohort, like for example, male is taken as a reference, and whether females have got more IRAs compared to male, that is what it is. And similarly, race in white. In Hispanic, no is a reference. Smoking, never smoker is a reference. So this is the various reference points which they have taken, and they have said that this particular subset has more IRAs. Next slide, please. And the next slide, please. So here, what they have taken PD1 as a reference point. So what they have found out that PDL1 is 1.21 is the hazard ratio. That means that PDL1 has more IRAs compared to PD1. Next slide, please. And similarly, if you see in terms of the subsite of the cancer, the breast cancer, the melanoma has been taken as a reference point. So the breast cancer has one of the highest incidence of IRAs compared to melanoma, which is taken as a reference point. Next slide, please. This was something which is very interesting. I thought the other way around. Now, this may not be true, but this is what the paper says, that if you do not have any IRAs, in that particular time, it is patient's overall survival is better. Now, whether this needs to be accepted or not, we will discuss when we ask Senthil and Tarini. Next slide, please. So what is the take-home message? Take-home message is something which we need to find out from Senthil and Tarini. So with that, can you close this, please? I invite the first person whom I always love to ask questions, Dr. Tarini Prasad Sahoo. In fact, the Tarini is a very, very dear friend. At the same time, he is the king of Bhopal, which undisputed king of Bhopal, and nobody can deny. Senthil is approvingly laughing about that. It is actually, if those who have not heard Tarini, please attend every moderation, whichever conference is going. I every time learn at least 5 to 10% new things which I had not even imagined कि ऐसा भी कुछ होता है करके. And Tarini, thank you so much for accepting and thank you for being an integral part of OBTO from the word go. Thank you so much for that.
Thank you. Thank you, Amish.
So, Tarini, this particular question is divided between you and Senthil, but I would request Senthil that the primary questions right now is to Tarini. But if you, Senthil, if you think that you want to add something, please feel free to do that, because today's topic is more of a learning rather than pinpointing a particular thing. I know this paper is not perfect, but at least it gives us some questions which we can try to answer. So, Tarini, first question to you is, do you actually believe in real world data and real world evidence, or you think that no, our understanding, our practice of oncology should be based on randomized controlled trials only?
I think real world data and evidence have a place in oncology, not only oncology in the part in the practice of medicine. So that's something we have to start believing. But it's also it is important that how the data has been collected, because in real world data there it is subject to a lot of biases. So before we draw conclusions, we have to understand how the data has been drawn, how robust that data is, because that is important for the real world data and the number of patients, and probably a uniformity of the treatment or the disease type in a real world evidence does make important things. But for me, what real world data really brings into the table is, if
So
it
you said
really.
you said you said there are
Yeah,
a lot of biases in when we
yeah,
collect.
yeah.
Does that mean that has the world reached a particular type of definition for real world data and definition of real world evidence?
No, they have. If you look across the literature, there is a definition as the USFDA gives it. But if you look into the literature, they have used it interchangeably.
Correct.
Basically, the real world data is that anything which you pull out of the electronic data, what you have for the patients, or the insurances, or such as the Florida, what you mentioned. So this is what the data is. And the evidence is more about the clinical evidence about the uses of the benefit, what benefit that particular thing is giving, or the toxicity that's happening. So that is hot. It is very thin line. But more so, what I get when I read the US FDA definition is real world data. When you interpret and put it in a scientific context, then it becomes evidence. That's what how I feel that is.
So do you think real world evidence or real world data can be prospective also, or it is always retrospective?
It can be prospective. It can be prospective, and I think that is people have to remember. So when I look into how important that data is, one of the thing will be retrospective, prospective. The biases will be lesser in a prospective.
Can you the real world evidence can be used for changing the practice
Yeah.
or expanding the label or in rare cancers. What I understand is these three things. Is my understanding correct, Tarini?
Rare diseases, yes, because you would be very difficult to find a randomized trial for a particular very rare subsite with, let's say, some rare form of skin cancers. That is there. If you have that real world cohort doing something and you have a data set that is consistent. If you have a genetic marker which is there, which is in very rare subset, you might not get a randomized trial for such. So their real world data helps in. To change practice as such, that becomes difficult. It is not, if it is not backed with the randomized trial. So I would not
Okay.
tell that practice changes, but real world data, what it gives is a thinking process, or probably a thought process on which a larger trial can probably run, or maybe maybe tell a yes no to what the real world data has probably told something.
Senthil, just yes or no. Do you believe that the real world evidence can change practice, or you agree with Tarini?
Yeah, I agree with Tarini. So we would not completely change practice, but it'll definitely put a thought into your brain saying, why not we do it like this? Why not we do it a different way, and so on and so forth. But if you really ask me, have I changed practice ever looking at real world evidence? I really can't recollect an instance like that.
Okay. So
And
let me.
can I come in
Yes,
a
yes,
very
Tarini. Yes,
what you
Tarini.
can really change is probably the dosing pattern. you will not make a drug as an indication for a new thing. That's what probably Dr. Sandil and I'm
Correct.
pointing to. You might
So,
come to a dosing pattern change or the type we dose. That could happen.
there are two examples which I came across. One is palbociclib in male cancer.
Okay, you're talking about drug approvals. That's not change
Yes.
of practice. I think there's a slight difference from change. Let's say I'm using
So
palbociclib
adding the
in.
label, that is what you are
Yeah, yeah.
saying.
So there is avelumab, there is blinatumomab, there is palbociclib. I think there have been a lot of instances like that where real-world evidence has been used to approve drugs also. That I agree, but would I call that change of practice? I wouldn't call that change of practice.
If you see the sorafenib real world data, sorafenib in HCC, sorafenib was the first drug which was approved, and we all were so happy. 20 साल बाद कुछ तो हाथ में आया. And I still remember Tarini always telling me that in the clinical trial, he always starts his patients with the full dose of sorafenib, right? The real world data after real world data, and if you see, there is a large collection of real world data where they say that 3.1 month difference between the control arm and sorafenib is not seen in the real world. And there are many people who have questioned that does sorafenib really do something to HCC? Tarini, you are aware of that real world evidence, right?
Yeah. See, there are two ways how I look at it. If you look at it in a trial setting, they take a particular set of patients who are the most fittest of the fit patient. So that patient data is many times not there when we are doing it to a general population where I'll be taking a patient who's not a typical A, I'll be taking a B, and some might be taking C's also. So that data set is more heterogeneous. So in a trial setting, more often you would get a probably better results than what you normally see in the real world scenario, except maybe Pacific R, where because you get a little higher than what a Pacific really reported. There are rare scenarios, but most of the time, because you get the fittest of the patient, you would get a real world scenario because the heterogeneity is there. You will take sick patient, much sicker, not fulfilling the criteria of a trial, and they're more heterogeneous. You might get a lower thing. So I would not read it that way. I read it that we have selected the patient of sorafenib in a real world scenario much worse than what a trial would have taken those patients to be. That's my understanding.
Got it. Got the point. So I get from both of you that to completely negate a randomized control trial approval, the real world evidence is lacking in that, and we will be little reluctant to cancel our practice based on the real world evidence. Is that correct? What I get from both of you?
Yeah,
Perfectly.
that's correct. We
So
would probably
the
modify the way we do things. We would not
right.
change the way we do things.
Right. So modified is something where Tarini, my next question is coming to. In the real world evidence, they always keep reporting that external control arm.
Hmm.
Okay, because we all want, and there's a very famous trial where they people observed that day 1, day 4, day 8, day 11 of bortezomib in multiple myeloma gives rise to a lot of side effects. And they wanted to do real world evidence of once a week bortezomib, and they refused to do the control arm of twice weekly or day 1, day 4, day 8, day 11 because they felt that it is unethical. And they collected the real world evidence, and actually people are practicing weekly once rather than day 1, day 4, day 8, day 11. Tarini, your point on that?
I actually, I'll be honest, I went through that when we discussed this, and I'll tell you how these real things happen. Yes, there were toxicities, there were thrombocytopenia, more neuropathies. So people were scared, and all of us have faced through when we started bortezomib first. So what happened is when they looked at the large retrospective series where people have done the real world evidence, that's where we are telling Sandil and me that it really adds on. Then what happened is people went on to do a post-hoc or secondary analysis on the bigger randomized trial. And then that also went the same way as the retrospective analysis were going. And the third part to prove that we are not doing inferior was we do have more than one now large clinical trial randomized way proving that the single weekly is not inferior, lesser toxic. So my point is that is what I spoke. The real world data does give you a hint, but that needs to be proven on a better platform, which is a trial. And that is how the bortezomib dose has actually evolved.
Fine, perfect. I get your point. Now let's come to real world evidence in India. Okay. And I famously quote Dr. Vamshi's paper, and Vamshi is the moderator here. Not that's why I'm saying that, but in HCC, there are many a times I am tempted in a child book, B8, B9, or patient is there, patient is fit. And I'm tempted to give them immunotherapy. And Vamshi showed in his data that B and C does not help. You should refrain from doing that. Uh, Am I right in deducting that? Or Tarini, you say that this was just, we were always told that only, see, the trials took only child book A, and there are very few trials they took B7. B8, B9 का तो मुझे पता भी नहीं है. So, am I right in telling patients you take that as evidence?
Yeah, it should be. Because see, this is what I spoke. The real world data is now going what the trials told us. So this gives more confidence on our
No, no, the
practice.
trial, majority of the trial did not include B9, B8.
So that's why, for a reason they did not include, for a reason that they are going to live very short, they have a poor prognostic factors. And what Dr. Vamsi and the group from TMH and Vamsi and data put together is that they did tell us the same thing, that really did not matter and we should be refraining and putting on hold what we're doing. So it's basically a little bit extension of what the trials have been telling us. So so it's important, because that's important, that if they collected the data in the right way, and all the hospitals which they collected had a robust system, you could have missed some data for sure. When we looked into a retrospective analysis, you will miss data, but their data looks robust because it is again in tune on how the world practices.
Right. So, Tarini, the other way around, if the B8 would have shown some benefit, what would you have done in your practice?
So if you have shown a benefit, I've seen the number of patients. Is it a chance finding if there have been 8 patients, 10
90
patients?
patients, say 90
So
patients.
no, I would not change practice. I would look for a much more data set, and if multiple real world data is pointing towards a similar point, then probably that things become more standard and someone will look into it. One data, then what I would do in my practice, how I do it, I search for other evidences in that patient subset. And if every the data set is pointing towards a similar point thing, we would do that. As we did it for gallbladder, the benefit of immunotherapy versus the non-gallbladder. We have two randomized trials, both pointing towards the same, and what all of us saying, do it, give it, intent to treat it has shown a benefit, but look, gallbladder does not benefit. So that is what I meant. So I would not go with one just aberration.
Right. So, one of the point maybe when Senthil starts is, because my first question also same, Dr. Aju Matthews' paper where, you were part of the author, that he collected the data of whether NGS really helps our patients or not. And it is one of the highly quoted paper, but it is actually something which is being quoted again and again. And people keep talking about utility and futility of NGS based on the real world evidence. But maybe Senthil, you can start with that. My one more question to Tarini is, why are we discussing this paper, Tarini, according to you? You give your feedback. Like, they have reported a lot of limitations. The author themselves have said that the grading was not discussed, hospitalization, whether it was because of IRA or not, we didn't know. Genetic profile and lifestyle was not included. Milder IRAs may would have missed, and only first year. Why do you think, or have I selected the wrong paper? You can tell openly,
Should I?
Tarini, there is no issue
Okay.
about that.
I went through the paper. Will I change anything? Will I draw any conclusion? My answer is very clearly no. Is it a
Okay.
good discussion point? Yes, it is a good discussion point. It opens up a lot more comorbid factors that could affect immunotherapy, but it does not draw any conclusions at the end of it, as the paper does tell you. The most important, what I feel, why I'm not taking it at face value, is that they just took it on a discharge summary, the end discharge, what was coded for, and expectedly they did not do it the CTCA grading. That is what really hurts me, because they have done any hospitalization within a month is a serious immune related adverse event. They have taken it as that. It could be chemo related, it could be disease related. They have not stratified on that. That to me really pulls back. I do not know how to read that, because all of us know grade 1 IRE. I understand hospitalization would have meant more, but I would take insurance hospital in India. They are admitted for multiple reasons. So if it is within 30 days, will I take it to IRA, which is severe? I would not. So that is of the many things which you spoke. This is one of the most limiting factor for me. It is not capturing what I really intended to see.
Okay, perfect. I think, Tarini, the last message to if the students, if they are attending tomorrow, if I want to do real world evidence, for example, I do a lot of liquid biopsies in this thing, and I say, let me collect data from 10 centers, and I write an email and one page form, I give it to all 10 people, okay, please help me. And I have got, say, 1,000 samples of ctDNA. Is that a real world evidence?
It is, but as I tell you, your real world data and evidence is as good as your what you have collected and how correctly it has been collected. So most important when it's going through here, there's a beautiful publication on the use of AI in real world evidence. And that maybe that they've used a large language learning thing. They wanted that the AI helps us in capturing what our normal eyes will miss. And that probably once it gets integrated, the more data set we have baseline, the more robust it is going to become. That is what I would tell the take home message. Record everything. Take the help of AI. Let the data at the baseline be very robust. That will make it a better paper.
Statistics, whom should you take the help from when the real world
Statistics,
evidence? I know my documentation is amazing, for example.
I
Parikh sir has
think
audited my documentation.
we
Is
all are.
documentation a no that or statistics should be help should be taken?
It should be taken because the number of events could be very different, and you will definitely discuss as it goes through that if events are less or events are more, which statistical unit will give us a better value for a binary versus a multiple things, what you should take. So these are important. We are not statistician. It is nothing to bad to take a help of someone who knows more. That's important.
Fine, perfect. So I take the conclusion that this particular paper questions, a lot of questions are being raised, but there is no conclusion which we can draw, which is fair enough. Real world evidence is good for us to understand the disease, but completely changing the practice or negating an approved label is going to be difficult for us as of now. And when we design a real world, we design it properly and we take the help of a statistician also. Unless until you have a proper documentation of the paper, the real world evidence will have a lot of biases and flaws. Thank you so much, Tarini. Tarini, you stay over and you can chip in when we are asking Senthil sir.
So my Viva is starting now, Amish.
uh, so again, Dr. Senthil Rajappa and I, we were together in China very early on when Novartis had invited all of us on how to give LAR, if I remember correctly, and it was many years back. Senthil was in Nizams and I was in Tata Hospital at that time. Today, I'm not ashamed to say, neither am I jealous to say, the caliber where Senthil has reached today is something which is to look for. Senthil, really, whenever, we, all of us, Ullas, myself, Tarini, Vamshi, whenever we discuss, we start thinking, Senthil boss kya soch rahe honge isme karke? So, Senthil, you have become a benchmark for all of us. And again, as I said, we all are very, very proud of that. There are a few other things which I have also heard, which I'll tell you when we discuss one to one in the forum. But
So two
Dr. Senthil,
Hyderabadi dinners fixed from Senville one and from Vamsi one. Two Hyderabadi dinners fixed.
Welcome, welcome, welcome. Anytime.
so Senthil, thank you so much.
Thanks, Amish, for
Again,
having me.
like Tarini, you are
Thank you for
integral
being
part
so
of
gracious.
OPTO. Thank you so much. So, Senthil, before I start shooting my questions, I wanted to ask you real world evidence, which was collected. First author was Dr. Aju Matthew. The utility of NGS, JCO publication, cited many a times, where it was shown that around 4% is the utility as compared to 7 to 8%, which was, published anywhere else. Uh, is that the true real world evidence, or is that the evidence you will take it and you will tell your patients that के देख भाई इतना ही है यूटिलिटी पैसा डाल रहे हो इतना फायदा होगा. Have I frozen or has Senthil frozen?
Listening to your
You're not frozen.
accolades,
Sorry.
Senthil has frozen. Listening to your
Senthil.
accolades, he has frozen.
Senthil, we can't hear you, neither we can see you moving. You can rejoin, Senthil. Yeah. Tarini, you can take that question meanwhile while we get Senthil. Aju Matthews
Yeah,
paper.
yeah. I think before Dr. Senthil joins in, I think Dr. Aju Matthews' paper is something. Yeah, Dr. Senthil is there.
There,
You can read it.
Senthil.
Yeah, I heard it. So I think that paper has to be, yes. I think if you're asking me a yes, no answer, is it real world evidence? Absolutely real world evidence without any doubt. So there was a lot of criticism regarding what the denominator should have been. So we took the denominator as all the samples that were tested are all the patients who had a test done. So when you take all the patients who had a test done as the denominator, then it comes down to 4%. But if you take patients who had a test done and then had access to a particular treatment, then that got better. So it depended upon how you decided on your denominator. In fact, I was the one who said the denominator should be all patients who had a test done. Because if you want to tell your patient, okay, I'm sending this test for you. If I had 100 patients like you, 4% of them would end up getting a targeted therapy. So that's absolutely true. And I'm happy to say that uh, that has been cited quite a bit over the years.
Perfect. Okay. So, Senthil, coming to this particular paper, I know in Delhi you asked me a question that why have you selected this paper? And I could see the expression on your face. But do you think that by sheer number of, say 6,000 patients included in the final analysis, are we relatively wiser as compared to IRAs, as compared to data from randomized control trials?
Okay, every piece of data definitely makes us wiser. So I don't want to say 3,000 patient data is useless. So let's start there. So I want to be positive when I say that it's a good data set. There's something that adds on. But there are a lot of things, just like Sahoo was pointing out, which you don't have clear explanations for, number one. Number two, there are a lot of data points which are totally contrary to what consistently a lot of meta analysis and randomized control trials have shown. So, how do you really take this piece of evidence to change your practice or modify your practice or change the way you think? So, for me, am I going to change the way I think when I see my next patient for immune checkpoint inhibitor? Probably not. I would keep my antennas up irrespective of whatever it is, whether they had a cardiac problem, whether they had a melanoma, whether they had breast cancer. But what dampens the results of this paper for me is that a lot of things which cannot be explained, a lot of things which are contrary to what evidence so far that has accumulated has really shown. So when a lot of these points, so for example, I'm sure Vamshi will discuss dementia. Why should somebody with dementia have, what's the relationship between dementia and immune related? Maybe there's some very remote biological explanation that you can give, but when you look at it truly, there's no great explanation that one can give to say why and what. Similarly, I'm sure Vamsi will talk about morbid obesity versus overweight versus, there are a lot
So
of things like
I'm not
that.
going to talk about obesity, Senthil.
Correct.
I
So I'm
agree
just,
with you.
so,
My point is
so
you
that's
you
the
you
point.
came to dementia. The authors have given some one-line
Correct. I'm
possible
not very
theoretical
convinced about.
explanation.
I'm not very convinced of. So you could explain. So it's like
If
saying
there would have been
chemotherapy.
two other real-world evidence which would have shown that dementia reduces IRAE, then would you start believing or would you still want RCT?
So then how would I change the way I'm going to do immune checkpoint inhibitor? I'm not going to. I would still be alert as much as I am today, whether it's
Okay.
somebody with dementia or without dementia. So that's the point I'm trying to make.
Perfect. I think it makes sense absolutely. So let's start with hospitalizations in this particular paper because we are supposed to discuss the results of this paper. Let's assuming that Nature, Precision Oncology, Open Access Journal have thought something before accepting this paper, and let's try to give some credit to the authors, assuming 8% is the hospitalization, and they clearly say that we really don't know whether this 8% hospitalization is because of only IRAs or because of some other confounding factor also. But Senthil, what percentage of your IRA patients end up in hospital? And I would request anybody who wants to write on the chat box because that is something which is extremely important to the patient. Now, right now, I have one patient who's admitted after immunotherapy for, I feel sepsis, but it is within 30 days of giving the immunotherapy. So, Senthil, your point.
I'd say 1%, 2% is what I would think.
just 1-2%.
Yes.
So this 8% what they have written is, a huge. Dr. Jethani
Correct.
writes around 5%, but I agree with Senthil. If I go back in my practice, I personally think is that, not even 5%. We hardly see any patients who have IRAs requiring admission, because nowadays we are more alert, as Senthil said. Senthil, 44% of patients, nearly half of the patients, had multi-site, more than one organ involved in IRAs. And they have reported that certain patients had up to 9 organs involved in IRAs. I look back and there are 2 organ involvement is not uncommon in my IRA data. Senthil, what is your take on that?
Correct. So all of us who've had experience with immune checkpoint inhibitors now know that more than one system can be affected by these IRAs, and uh, endocrine seems to be so very common. I think 60,
Correct.
70%. So if you take that as one, then easily about another 20, 30% of patients would end up having some degree of another system also being affected. Now, this may not be severe, it might be grade 1, at best grade 2, because as you said, we now know how to pick this up early and act upon it. So, multi-system is not uncommon at all. If you say anything more than one is multi-system, but if you really are looking at 4 and 5 and numbers like that, that again is very rare. I probably would have one or two patients that I can think of who had multi-system. The other thing is when your mind does not know, the eye does not see it. So sometimes these small minor ones kind of get passed away. Overlapping toxicities with chemotherapy, overlapping toxicities with targeted therapies that happen. Sometimes it's very difficult to say what is causing what. So some of these have probably been, pushed aside, saying this is probably unrelated to the immune checkpoint inhibitor. So maybe it's a little higher, but not high to the point where we can say multi-system is so common.
So, in endocrine, patient comes to you and says, "I have fatigue." Fatigue is one of the well-known IRAs, if you see. But we like to brush aside कि यार कीमो भी मिल रहा है तो fatigue तो होगा ही ना आपको. Senthil, what do you do about the fatigue particularly? Because I have had at least 2 patients where I had to stop immunotherapy because of grade 3, grade 4 fatigue.
Correct. So I used to do this earlier, Amish. I was like you. Now I'm slightly
That's
better
why I
than
say
you.
you have moved ahead of all of us.
So now my threshold to get ACTH, cortisol, and electrolytes is much lower because I've now seen quite a few patients with hypophysiitis, not
Right.
necessarily with the CTLA4, with just PD1, PDL1. I've seen quite a few hypophysiitis now, and it's so dramatic the way they turn around when you put them on steroids. So I very frequently now have started doing all of these. If I find somebody with significant tiredness, don't ask me what significant tiredness. When they come and say, "Really, doctor, I'm not even able to do my day-to-day activity," something like that, and they're on immune checkpoint inhibitor, I definitely go chasing all of these apart from the routine things that we would do to rule out anemia and stuff like that.
I completely agree, and thank you so much, Senthil, because I thought I have a plethora of hypophysitis right now, and because we all are chasing, and what asymptomatic hypophysitis, I try to put them on 7.5 mg of Visolone, because this is a physiological dose as suggested by endocrinologists, and almost all patients do very well. But how to manage hypophysitis, Senthil, somebody has asked that question very quickly. If you
Correct.
can answer that.
So if it's grade 3, grade 4, then again it's managed like any other adverse
Correct.
AE. So you would start with 1 milligram per kg body weight of steroid and then slowly start tapering. But it's not severe, then you just do the replacement dose. What I use is hydrocortisone. We use Histone 20 milligrams morning, 10 milligrams afternoon, and 10 milligrams night. So that those people just turned around like magic. But if they're going to go, so one of the situations that we commonly encounter is triple negative cancer, going in for surgery after having hypophysiitis, especially when the adriamycin phase of that, neoadjuvant chemotherapy. So when somebody is going in for a procedure, we kind of double the dose of Histone that we give because that's a stressful situation and you need more corticosteroid. And when they finished with that, we gently go down. So that's what we would do. I
Right.
think, Priyanka, maybe we should take your
Right.
questions in the panel later. So
Right. Perfect.
we would be
Perfect.
digressing. Sorry about that, Priyanka.
Right. So, Senthil, what this particular paper, coming to this paper, whatever conclusions they have drawn, but they have drawn the conclusion in a statistic way, and I have shown the graphs where they say that patients with breast cancer has got more immunotherapy side effects. Patients with multi-site has got more immunotherapy side effects, and people with brain tumors, I feel brain tumor, they don't live long. They get less side effects, while hematological cancers have got more, and hematological IRAs is to the tune of 5.4%. I quickly would want you to answer all these questions, Senthil, whatever understanding this paper gives us.
I think except the hematological and probably melanoma, uh, I don't think we have clearly a good explanation to say why the incidence of immune-related adverse events are higher in some of these malignancies. For example, malignancies that are more immune dependent, for example, melanoma, kidney cancer, all of these situations you probably expect a slightly higher incidence. Hematology, because that's the system that is actually affected also. So you probably are having a higher incidence. I really can't explain why somebody with breast cancer should have one of the highest incidence of immune related adverse events. So again, it's real world data, it's real world evidence, it's there to stay. But again, I come back to the same point that I was trying to make. Am I going to use this data
Change.
to kind of change my practice or change the way I look at a patient with immune checkpoint inhibitor tumor? Probably not. So I think that's the point.
Second last question to you, and then the last question. Second last question is the burning question: overall survival. Now, this was something very confusing, Senthil. If you have IRAs, you are going to live shorter, is what this paper said in a broad aspect. Then they have tried to do subset analysis and all those things. But do you really, really believe this particular?
Okay, so let's go back and look at what's the large body of evidence saying. So the larger body of evidence, meta-analysis, and all of them are saying that if you have an adverse event, immune-related adverse event, then your likelihood of surviving is actually better.
Better, correct.
Now, there are some meta-analysis which have looked more at more granular data, and then they say if you have a grade 1 and 2, you seem to be living longer, but you have a grade 3 and 4, you seem to be living shorter. And the reason why you're living shorter is because you're needing more steroids, and so steroid related issues, immunosuppression, so the malignancy also starts worsening, and so on and so forth. So we really don't know the answer. In fact, there is also some data to say that if you quickly jump to the second line drug, that means you start with 1.5 milligram of steroid, you go to 2 milligram of prednisone. But if you quickly jump to a second line drug like mycophenolate or all of those other drugs that we rarely kind of use, those patients seem to be having good outcome in spite of having a grade 3, grade 4 adverse event. So I think we really don't know the exact answer to this question. The large body of evidence points to the fact that if you have an IRAE, your survival is better, but this one is to the contrary. So I think the truth is somewhere in between. Some IRAEs probably lead to better outcomes, grade, site. We really don't know which of those lead to better outcomes and which can actually bring down your curve.
Right. So Tarini just said that mild IRA survival is better.
That's what I said. So
Is that the grading associated with survival, or we really don't know that answer,
I think
Senthil?
we will, but Sao is right. I mean, that's the data set probably I'm also quoting. So mild ones, they seem to be doing better. But poor ones, they seem to be doing poorly. Again, we don't know why. People think it's the steroid and so on and so forth. The break in treatments, all of these things might actually end up compromising the outcome. We just don't know.
Right. So, but we cannot take home message about IRAs and overall survival. Am I right on that point, Senthil?
We can't say, see, all of these are post hoc analysis, right? So
Right.
we really can't say that, okay, I can't tell my patient, oh, you had an IRE, great, you're going to live longer. So I'm not going to make a statement like that to my patient. Okay.
Right.
So I think we need to take all this with a pinch of salt, a bag of salt, whatever it is. Again, I come back to the same point. Am I going to change the way I manage? No. I'm just going to stick to the guideline and say, okay, you've got a grade 4 event. You can't go back on the immune checkpoint inhibitor again. You got a grade 2. Wait, get back to the immune checkpoint inhibitor. So that's the way I will look at it.
Okay, perfect. So I think my last question, otherwise Vamshi is going to kill me that I'm taking away all his time. Uh, this particular paper says that if you keep the PD-1 as a reference point, PD-L1 has a relatively higher incidence of certain IRAs, including hematological. So, Senthil, let me ask, in an adjuvant non-small cell lung cancer, we have pembrolizumab also approved and we have durvalumab also approved, or atezolizumab also approved. Would your thought process, assuming that this data set is correct, assuming, okay, if you have a choice of PD-1 and PD-L1, both are equally category 1 recommendation, would you select based on this?
So Sahoo wants to say atezolizumab, it looks like. So he wants you to declare conflict of interest
No,
here.
there is no conflict of
Okay.
interest. This
Okay, Amish,
particular
so
paper is
so
not
no.
sponsored by
So
anybody.
I will not decide on which drug is going to give me lesser adverse events and choose. If the indication is there, then I will use the drug. I'm not going to substitute one with the other just because there's some data to say that the IREs may be lower with one drug compared to the other. Again, just a short, a summary of this. The
Yes,
body of
please.
evidence is again pointing to the contrary. The body of evidence is clearly saying that PDL1 has a low incidence of immune related adverse events compared to PD1, and the reason is whether you're able to block or unblock the PDL2 axis. PDL2 is inhibitory. So if you're going to use a PD1 that's going to block the PDL1, PD2, PDL2 also. So you're likely to take your legs off the brake a little more than what you would do with the PDL1, and so the immune related adverse events are supposed to be higher with the PDL1, PD1, sorry. So PD1, based on the data, higher adverse events. PDL1 is lower, but this paper is to the contrary. So I'm not going to take this data to decide on what drug I'm going to choose.
Thank you so much, Senthil. One of the point is that people who are listening is that just because it is in Nature Open Access Precision Oncology Journal, just because you have a 6,000, 7,000 patient data set, the real world evidence, fits into all the definitions which are given by US FDA, does not mean that it is compelling for you to change your practice or change the treatment the way you want to. And I think this was clearly highlighted by Dr. Senthil and Dr. Tarini, and I thank you so much, both of you. And with that, I invite Dr. Vamshi. But both of you, please stay forward because Dr. Vamshi is going to moderate for next 45 minutes, Vamshi. That is what the time you have. And if you can please invite, Senthil said younger patients have more IRAs. This particular paper said 18 to 29 because they have some energy of that immunotherapy. I think
Correct. Tilak has
Senthil and
asked that
Vamshi,
question.
yeah,
Tilak has
Senthil
asked
and
that
Vamshi
question.
can take that. So Vamshi, over to you. Thank you so much. And I'm sorry or happy to quote your paper on HCC. If I have missed out, apologies for that. Over to you, Vamshi.
Good evening, Dr. Amish. Thank you so much. And just want to invite all my panelists, Dr. Sahoo and Dr. Senthil. Of course, we have heard them till now. My good friend, Dr. Viraj, who I can see there, Dr. Soumya Panda from Bhubaneswar, who is also here. I saw Dr. Safalta. Again, the good friend Venkat is there from Chennai. Dr. Kanhu Charan, who is a radiation oncologist but has a very wide range of interests. And I will ask a few radiation questions as well. And Dr. Dhruv Mehta from Surat. So, if I can be allowed to share my slides, please. Yes, let me just try and share my slides. And what I will do is this is the panel discussion. Now, I'm not going line by line into the paper because Dr. Amish actually said that he would be doing that with Dr. Senthil. So, Dr. Senthil, I'm not taking a few of the points that you highlighted, but I will try to
No problem.
discuss
Yeah.
how are the IREs being done, how do we actually manage them, and how do we look out for them. Now, this was the paper that we were given, the NJP 2025. So, let me start with a very interesting question to anybody who wants it, Dr. Safalta or somebody who hasn't spoken till now. Dr. Safalta, where are all these authors from? You look at the names and just any guesses?
Chinese?
Okay. Dr. Dhruv, your thoughts?
No, mostly Chinese or
The
I
Chinese.
think,
Okay.
yeah.
So Dr. Venkat, I'm just basically asking everybody till I find someone who has read the paper. So, Dr. Venkat?
Sorry, Vamshi, got a call from ICU, so give me 2 minutes.
Okay, no problem, no problem. Dr. Soumya.
Yeah, Chinese, but Chinese working in US probably.
Perfect. So again, this really struck me very interesting when I saw the authors. Like everyone, I thought they're Chinese, and then I read the first line that it is from one Florida group, and all of them actually are working in various Florida and such places. I think Minneapolis, somebody. So all are from USA, and essentially what they have done in this paper is they have used a kind of a EMR or a EHR to look at the IRAs or the adverse events, and obviously they could not see what grade they are. So they just looked at the EHR broad summary to decide about this paper. So that's point number one. Number two, Viraj, any paper that we look for, what do you think is the impact journal for this journal? Impact factor for this journal? We have been talking of precision oncology. What's the impact factor? Dr. Viraj, any guess?
No, I'm not aware.
Not aware. Okay. Dr. Kanu, you are again doing a lot of research and article read. What do you think is a good impact factor to include a article for OBTO or anything like that?
So at least 5 to 10.
5 to 10. Okay. Who have I not taken? Dr. Safalta, your guesses?
At least 20.
20. Very good. So, Dr. Amish, you are being very diplomatic and nice, as was Dr. Senthil and Dr. Sahoo. Impact factor for this is 8 as per 2025. So
That's
I
not
was
bad. That's a good impact factor.
exactly. So it was a little surprising because there are certain things in this paper which kind of
NP.
a
If I
surprising.
may I add something? Sorry, I was on a call.
NP1.
Yeah.
I think impact factor should not be yardstick because, say, for example, pediatric blood and cancer is the topmost journal for pediatric oncology, has impact factor of 3.2, but the
Oh,
best articles get published. And if you
okay.
know, most of the Nobel Prize winners didn't publish their papers in high impact factor
I
journals.
agree.
As a matter of
Agree.
fact, they got. So we should use it as an
Agree.
yardstick for selecting.
Agreed. So, Dr. Venkat, since you're back from the ICU, before you get dragged into ICU again, quick question. This paper for me was all about the headlines. And the biggest headline for me from this paper was that incidence of IRA, which is 56%. 56% was the IRA incidence out of your patients, and that number struck me. What would you say is the incidence of IRA in your practice?
Ballpark clinical, I would say about 15 to 20%.
15 to 20%.
15 to 20%. Yeah.
15 to 20%. Okay, Dr. Soumya?
Yeah, it will be around something like around 10% if we include all the grades maximum.
10% all grades. Okay, Viraj?
No, it's quite more than this quoted. Like I have at least 40-50%. If you start
50.
doing TSH and start seeing rash
Okay.
and fatigue, usually majority of them have it.
Okay. Dr. Safalta?
I agree with like 30 to 40%,
30
especially
to
that
40.
thyroid and hypothyroid and then rashes.
Okay, Dr. Dhruv?
Yeah, so if we include immune-related cutaneous adverse events, then definitely around 40-50%.
40,
But
50%.
most of them are like grade 1 and non-specific maculopapular rashes, and most of the patients don't complain.
All
So
right.
they, yeah, so.
So, Dr. Sahu, your take on this, because we, at least when counseling patients, many of us would tell them serious side effects as compared to chemotherapy is only 2%, 5%, and now we are talking 50%.
No,
Dr.
actually,
Sahu,
Vamshi, if you look at this paper, how they've taken this thing,
I
so
will come
that
to
is
that
one.
next slide. Dr.
Yeah,
Sahu, I'll come to that
that
next
is the
slide.
reason why this
No,
is that high.
no, but I am asking you in your practice, what's the
No,
incidence?
no. So not as high. If all grades, it would be 20, 25% or 30 maybe. If it's serious, it would be 1, 2% as was spoken earlier.
So somebody has asked about low dose immunotherapy, and I will address that later. Let's park it for the side for now. Dr. Senthil sir, your take again. First two parts. What is the incidence? And number two, how often do we actually document grade 1 skin reaction, grade 2 skin reactions? Do we ask? You did say that you're doing more TSH and ACTH now. We do it as a routine every 2 cycles. But what would be the incidence with all this done?
So I would agree with Viraj that it's about 40-50% of some adverse event, but serious adverse event needing, interventions, stopping treatments, that would be about 5%, 7%.
5%. Okay, very good. So again, the reason why I brought this paper for me was an interesting paper because this is what they did. They took 17,000 patients. On the first point, they excluded 7,700 with pre-ICI immune-related conditions, which means 40% of their patients had pre-existing immune-related conditions. 43% with immune-related. Now, I am assuming that they mean people with ILD or people with psoriasis or people with something else. Dr. Senthil, how do you account for this? I mean, 40% of patients in our practice, would we still give immunotherapy?
That's correct. So this number is not commensurate with what you and me would see in daily practice. In our practice, less than 10% would have or come to us with some
Correct.
pre-existing autoimmune condition.
So let me put the question a different way. Viraj, which are the immune conditions which you would say, okay, absolute contraindications for, immunotherapy?
Transplants is one.
Okay.
Active vasculitis, people,
Yes.
or active rheumatoid. So, and like
Rheumatoid.
Senthil's
Okay.
active.
Rheumatoid. All
Uh,
right.
so in my practice, less than 5% would fall into this cohort. Even
Correct.
if they had some immune disease sometimes back and since last 10 years, they are stable, I would not exclude them.
Okay. So at least I feel like in my practice, we see a lot of GI cases. So we have CBDs, we have celiacs. Technically, these are all immune conditions. Or maybe you're talking of psoriasis.
Celiac is a very underdiagnosed problem.
So maybe you're
Majority.
talking of IBS, which could be having some immune related, or maybe you're talking of the psoriasis, the skin rashes. Maybe that's what the 7,000 has come from, but this was something that I could not understand. The second thing which Dr. Sahu was alluding to is how they have calculated. And again, very interesting. When you actually, what they have done is they have taken this 2,861 patients who did not develop IRA after 1 year. And those are the patients whom they added under the denominator and came up with this 56%. If you actually see the entire patients who did not have IRA within 1 year, the number falls to 40%. And if you actually take the full 16,000, your number is 21%. And 21 is, I think, somewhere where all of us would accept that, perhaps that's a number that I can accept. So, Dr. Venkat, is that a, reasonable description from my side, or do you think I'm just nitpicking the numbers? It doesn't matter really.
I think I agree with you. Yeah.
Because when I read this headline number of 56%, it was kind of shocking. The authors did say they did not differentiate grade 1, 2, 3, 4, but still, this bigger number is kind of a little surprising. Dr. Soumya, your take on these numbers?
I agree to that. When I also read the paper, I was a little bit I also saw the number, so it was not confident.
So this is actually our experience, which we had presented in this year's NCCN conference, not 7,000, 10,000. We had only 229 patients. And again, we saw 7.4% toxicities. Very important to note all the caveats of a bad retrospective analysis, which is because we could only document those who had really significant enough thing that was entered in the EMR or our follow-up notes. But this was the toxicity percentage we found, 17%, which is around 7%. And I think this is somewhat more what we would see in a real life situation. So again, this is what we found. So let's start off. First, let me dump straight into this question about the IO mattering. Dr. Safalta, when you're writing an IO, would you say, okay, this is PD1, this is PDL1, this is CTLA4? Where do I anticipate more side effects? Or you just anticipate for everybody?
No, so like CTLA4, they will cause more side effect,
Okay.
and then PD1, and then PDL1.
Okay.
So,
Sure, go ahead. I'm listening.
and what is this lag?
What? Excuse me? Lag. Okay, that's the other one, which is rare. We have not seen it. Some few new lags are coming in. So anti-lag, anti-lag also coming in. So that's why I
Okay.
just added it for completion's sake. So Dr. Dhruv, your take on the first three, let's say PD1, PDL1 or CTLA4. Given a choice, would you say I will use one over the other just because the toxicities matter?
So we all know basically IO plus IO will definitely have more side effects. But when we compare only monotherapy within PD1, PDL1, then I won't be rely on whether it is PD1, PDL1. For me, in my practice, like all are same, PD1, PDL1.
Okay.
Definitely
Viraj?
combination,
Okay.
definitely more side effects.
I agree. For toxicity point of view, PD1,
Yes.
PDL1, I don't find any much difference in practice. The moment
Okay.
you add on CTLA, few percentage points, the toxicities go up.
Great. So again, this was something which Dr. Senthil alluded to, and I found it interesting too. In this paper, they took PD1 as the referral, and they said PDL1 plus PD1 had a higher incidence, and CTLA4 plus PD1 had a higher incidence. So this is kind of opposite to what we think of routinely. And again, when you saw that when you combine with chemotherapy, the toxicity is less. And I wouldn't really understand whether this is the way we look at it. So, Venkat, your thought on it? This is just what they observed. So, do we just take it seriously, or we just shrug our shoulders and say, okay, that's what they found?
No, is there a biological explanation why the
No, they
toxicity
don't have.
is less? Yeah, because
They
the
they
first
could not
question
give a biological explanation.
you have to, then it's just probably chance.
So Vamshi, they have actually given a biological explanation, which I am not happy to accept. So
Okay.
they said that, with chemotherapy, all these immune cells are going to be suppressed, so you've got lesser adverse events. So, it is actually counterintuitive. We have all
Correct.
been taught to believe that when you use chemotherapy, it increases expression of PDL1, increases this and
T
that
cells
and
will
everything,
release.
and so the immune checkpoint inhibitor is actually going to work better. So
Correct.
that's why I was telling Amish, a lot of what they have said, I'm not
Correct.
really convinced of their biological explanations.
Correct. So, and I think what I completely agree with your point that, at the end of the day, you're going to look at the data, you're going to look at the trial, and you're going to look at basically which is giving you better thing. So that's the thing. That's what I would look at. All right. So next dose, sorry. So the other thing that we will discuss is what is the common IRE that we see in our practice and what are the common sites that we are looking at. Again, if I can ask Safalta from your side to start.
Most common what I see is hypothyroidism and skin rashes.
Hypothyroid skin rashes.
Yeah.
Okay. Anything else from anybody? Dr. Soumya?
I agree to that the most common is hypothyroidism, and then sometimes skin rash can be there.
Okay. Uh, Dr. Dhruv, your take. So hypothyroid, everyone is now looking for. Skin is something we are looking at. What is the next common after that?
Neurological, and then maybe like colitis.
Colitis. Okay.
Yeah, neurological definitely. I have seen more patients of immune-related neurological side effects like neuropathies and
Oh,
uh,
neuropathies. Okay. That's kind of interesting. Okay.
yeah.
All right. So hypophysitis is what someone has said. Is it more common? Okay. Is the hypophysitis that common for everybody? I mean, anyone can take that. Dr. Viraj, your
So
take on it.
fatigue is not uncommon, and like Senthil sir said, if we start poking these fatigue patients, you find this hypophysitis picture. Uh, I was initially not looking into at that and giving everybody 5 to 7 milligrams steroid, and they were all happy. But in reality, they were all hypophysitis.
Mhm.
So these three would be the top: rash, hypothyroid, and fatigue. But
Okay. Rash.
everybody has seen all organs, I'm sure.
Yes. No, we are seeing the comments. So people are
All
writing
organs.
hepatitis, and then I
And
had
since you are in GI, you would see more hepatitis.
absolutely. I was about to ask you about that, but then I
Correct. So
thought
hepatitis is quite common.
hepatitis
Quite
is
Hepatitis is
quite
common,
quite
especially
common.
with HCC.
And then we haven't seen pneumonitis. So, at least on the chat box, I have not seen
yes.
pneumonitis. For
Yes.
me, it's
That's awesome.
hypothyroid, skin rash, hepatitis, pneumonitis. I have, fortunately, again, touch would rarely come across problematic neurological adverse. I
Yes.
don't want to see
Neurological
all
has
of them.
been less touch
I
wood.
don't want to see them.
Yes. So, Dr. Venkat, let me ask you this question. When do you actually start looking for an IRA? Does the time matter? The first two doses you relax and sit quiet, and then from third dose onward, you start looking for them, or are you aware looking for them from day one onwards? Dr. Venkat.
From day one, we have had
Day
patients who
one.
had myocardial infarction within 6 hours of getting immune checkpoint inhibitors. One patient came with mesenteric infarct on third day. So we had really weird,
Venkat, the
yeah.
pathos in your voice is like a tragedy act heroes. I have to say, one of the old time tragedy actors. I can see your mouth so drooping with.
Oh, no, no, from day one, from the time you give
Okay,
infusion. And
fantastic.
just now, the patient who I got the call from ICU got Pembro 1 hour back, and she's having hypotension now. So we're moving into ICU. So
And Dr. Sendil, today my patient had
real
pneumonitis.
world evidence going on in the background.
Agreed, agreed. I had my patient today with pneumonitis who is on tapering dose of steroid from today. So I agree with you. Pneumonitis is not a.
Correct.
And by the way, that
Pneumonitis.
was yeah, and that was with one of the newer so-called Chinese IOs. So for those who believe that only it will happen with Nivo and Pembro, no, it happens with every.
And it is happening with everybody and everything.
Correct. But one thing is that generally, this is the pattern that the skin is early. Hypophysitis is typically a little later. Not again, like
Correct.
people said, it happens with people, but typically a little later. Cardiac and neuro can happen at any time. And that is something which we by now we have all understood that, monitor the cardiac and the things at any point of time, anything can happen. Dr. Kanhu, slightly shifting the topic today. Your medical oncology colleagues are jumping to give IO everywhere. Does it make a difference when you're planning your radiation, or the other way around? If you have already given radiation sometime, do you think that affects the IO and its toxicity?
Yeah, mostly the people tried with mostly in the lung cancers, where if you see the specific trials and everything, keynote trial. So most of the chances of pneumonitis is high. Other people, other things, I don't feel it. Though some people are after radiation, and if there is they are doing the immunotherapies and everything, we don't feel any much side effects. Mostly related to the lung, it is the most common toxicity after radiation.
Okay, so can I ask you this abscopal word we keep hearing in radiation? They say
Yes.
one part the immune cells will get active, they will get hot, and they will suddenly start acting very nicely with your immunotherapy and go kill everything in the body. I mean, is there been any evidence in the last few years for this? I mean, I've been hearing this abscopal word since my DM days. I don't know if there's any strong evidence as of now for this.
So, I mean, not clear cut data. So, but people tell ki the abscopal effect. As you told, we are hearing since our oncology practice. But abscopal effect and toxicity, I am very not clear.
Okay, Dr. Senthil, final word from you. But let's not spend too much time here. But RT, does it really impact your IO and its toxicity? Does it
No,
increase the
no, no.
incidence?
No, I'm just a little careful when it comes to lung. If they're doing so, sometimes oligoprogression we end up doing radiation therapy. So I keep a closer watch. That's about it. But I don't avoid a treatment that the patient deserves just because I'm giving IO.
I agree. I think Dr. Viraj will agree. In HCC also, we are giving
Correct.
SBRT. We are not really finding it as long as your doses are within the limits that they're supposed to give. So if you give it the way it's supposed to, generally doesn't increase the effect is what I think most of us would agree with. Fantastic. Okay. So now, before the thing, I would just want to go into one other issue of what are the uh, places where you suspect which will cause more, and especially I am bringing this about because Amish wanted me to cover this. The IO mattering, and more important, does the low dose IO make a difference? Because again, everybody has been using low dose for some reason or the other. Do we think that the low dose is better in to reduce the IO? Dr. Venkat, if I can start with you on this.
No, I don't think so. Doses make a difference. It's not the dose dependent immune reaction. So even patients with low dose can develop severe toxicities. And some of the patients who had grade 3, grade 4 toxicities in my experience actually got low dose because predominantly we use being a charitable hospital, majority of patients end up getting low dose.
Fantastic. Do you have your own data on this, or have you analyzed your own data on this? I'm just curious.
Not yet.
Not
But
yet. Okay.
anecdotally, we know that about 80% of our patients are on low dose. So
Dr. Amish is saying that he has seen all IRAs with low dose as well. Dr. Safalta, your take on this? Because, we, at least chemo wise, we tend to believe that if you have lesser dose, your toxicity is going to be lesser. Is that the same thing with the low dose IO?
So, as like ipilimumab, if it is given 3 mg per kg, then it is like higher toxicity. If it is 1 mg per kg, it is having lower toxicity. So there can be some relationship. Low dose, whosoever patient I have given, I have seen grade 3, grade 4 skin reaction. It was Steven Johnson in low dose, one
Okay.
patient.
Steven Johnson.
Otherwise, usually patients have tolerated well.
Okay. Dr. Soumya, your take on this. Again, you have been using low dose, I'm sure, quite a bit, especially since Vijay Patil's paper came out. Ashish has presented quite a few papers on low dose. What's your take on that, Soumya?
Yeah, so I have also used low dose, but coincidentally, the patient whom I had lost due to the IRE was a regular dose, the pembrolizumab plus axitinib in RCC patient. So maybe that is the one which I remember. But low dose does also have IRA.
Okay. So,
Single
Dr. Dhruv, do you think the dose matters? I mean, in terms of the IREs. Viraj, I'll come to you. Yeah.
I have given low dose nivolumab. The one thing I have noticed that they given low dose, I have seen skin rashes at least are
Okay.
there. And fatigue is also one of the things which I have seen in low dose nivolumab. Rest other IREs have not seen yet with low doses. As ma'am said previously, definitely for ipilimumab higher dosing, we have seen more IRAs with EP, but for PD1, PD-L1, I have not seen. At least for nivolumab, I have not seen.
Okay, perfect. Dr. Viraj, your take on this. You
Yes.
did your
So
hand up.
last year, GI ASCO, we presented our real world data of altered dosing versus standard dosing
Correct.
for MSI high non-colorectal real world analysis. Of course, the efficacy was same, but even the toxicities were same.
Yes.
So, and even in my practice, you cannot get escaped with this IREs, even though you use low dose. Interesting point about CTLA. CTLA is the only immunotherapy so far in randomized trial to show that dose matters in efficacy. We know 3 mg versus 1 mg better in liver cancer. Same thing, tremelimumab, 12 vials is better than 3 vials. And hence that low dose CTLA were stopped midway in STRIDE and the checkmate studies. So there one may argue that high dose leads to higher toxicity, but for PD1, PDL1, I think so we have reasonable real world evidence to suggest that they will be there.
Fantastic. I think Ravi has put in the thing that it may not cause it. Again, like I said, most of us have seen with low dose, and I have seen pneumonitis with low dose nivolumab. I've seen mouth ulcers with low dose nivolumab. It does happen. Now, the interesting thing, this was the paper by Vijay Patil originally, which actually started this whole, I would say, concept of giving low dose, at least in head and neck. And in his paper, they showed a total grade 3, grade 4 toxicities of 55%. But specific mention of IRE was not there for various reasons. I'm not sure the reason. Maybe it was published later. I'm happy to be corrected, but I couldn't find it. The other paper which was given was by the CMC team, which came this year. Among several papers, this was one paper, and they looked at again low dose induction chemotherapy plus nivolumab, and they found IRAs in 11.7%, including hypothyroidism. So again, it's not unknown. So as a general, I think voice to the public saying that people who think that if you give low dose, you won't have side effect, not sure that's the right way to look at it. Dr. Sendil, is the era of low dose over today with the generics launch? A very
I heard that the
crucial
price
question.
is as much as the Chinese IOs, so I don't think the era is
Okay.
gone. So
Okay.
I'm
So
actually
low dose is still
disappointed.
there.
I'm actually disappointed.
Oh, okay. I'm actually okay because I don't generally use low dose, so I'm happy that at the full dose, at least the prices have come down. That's my take. But again,
It's better than what it was,
better
but
than
it could have been better.
could have been better. Okay, excellent. I can expect some hotline calls between you and certain people and certain discussions to start very soon with these public statements, right? But anyway, this was about the low dose, and I think Amish really wanted me to cover this part about the low dose, and he wanted the opinion of everybody. So, Dr. Amish, your thoughts on this low dose? Because clearly everyone says side effects are there, and they don't necessarily seem to be lesser. So, Amish, Dr. Amish, Dr. Amish,
सर
are you there?
क्वेश्चन सॉरी
Yeah.
आई कुड अंडरस्टैंड योर कॉन्सेप्ट बट क्वेश्चन मुझे क्या है
Question to you because you specifically asked me to cover this IRAs in low dose. So, was there anything else that you were expecting or you were thinking of the answer when
No,
you asked
so
me to?
my myth, my understanding was that 40 mg would be definitely less IRAs compared to 240 mg. That was what. Once I had one patient of grade 4 IRAE and I called Kumar and I asked him, I said, Yaar, ye kya hai? He said, you'll see all types of IRAs with low dose. And that is what actually I am seeing. All types of IRAs with low dose also. So I just wanted to highlight this particular point
Yeah.
in the context of Indian publication, that what is it that other people are also reporting or they are experiencing.
So, I think you got your answer. Everyone says that yes, it is there. It will not be, and frankly, not huge
My
difference in both the things.
So my latest victim is a myasthenia. It's my first case in my career. Myasthenia post 100 milligrams of sertraline, 3 doses, and I couldn't even pick up actually because like Senthil sir says, your head doesn't know, your eyes don't see. And I was like,
Yeah.
what is happening to this guy? A neurologist says myasthenia, all the biomarkers negative. We gave steroids and he's like,
So
Fantastic.
Dr. Shiris Alurkar also recently, I think, published one case on myasthenia viraj. I think, so probably slowly, once we
No,
know,
I'm
we'll
saying
take
it
up
was
these things.
100 milligrams sir, please. So low dose, you
Okay.
cannot get away with toxicity. That's what I'm saying. You
No,
will
that
So,
still
I,
find it.
Vamshi, let me ask you as a program director. I have that luxury of asking you. Do you think that it is the low dose? Is it the right dose? Because I think Vijay Patil and Kumar Prabhash, they came to the conclusion that 3 weekly nivolumab of 40 mg saturates all the PD-L1 receptors, and you don't need to actually give the higher dose than that. Is that the understanding, or is the low dose is becoming an illusion nowadays?
I will go out on a limb since you asked me, and I will say I personally do not believe as much in this low dose as we are. And I think we are going to continue using the standard doses in most of my patients. The only patients where the low dose I'm still okay to use is an MSI high, because I think there's a very biological rationale why a low dose will also work there. Aside from that, remember that a lot of the disease, at least in GI, you're getting only incremental benefits of 2 3 months. You're not getting this huge doubling of survival, what we see with lung cancer, for example. In lung cancer, you are having long term survivors. In head and neck, you're having those. Kidneys, you're having. So maybe there a lower dose might be effective, but how low, we don't know. What is the low, we don't know. That is my take on it. And
Correct.
honestly, I feel that now the Chinese IOs have come, now the cost of the Nivo have come down. I think we are slowly going to see this. Given a choice, if a patient can take it, would you still insist on giving a low dose just because you have this paper? I don't think anyone is doing that right now. With all due respect to all the authors who have published their data.
So Chinese IOs now next, our point of discussion sometime later would be, do they cause the equal IRAs or not?
Correct. So I was about to ask that because, again, since you have brought out the topic, let's ask everybody. Safalta, your take on this. The toripalimab, Tislely, and Serplumi, and we might be getting Sinteli soon. What's your take on it? Would you think the side effects are similar, less, more?
So side effects would be similar. I
Okay.
have used toripalimab in 3 patients, and I did not see actually any side effects in that patient, in these
Okay.
3 patients. And
Okay.
rest, tislelizumab I have used in one, but it was just 2 doses, and then patient could not take more.
Okay.
So yet to have that experience.
Soumya, your take on this?
I haven't used much, only 3 patients, haven't developed any IRA so far.
Haven't developed any. Dr. Dhruv?
Yeah, I have used all three. I have definitely seen similar incidence of IREs in Chinese molecules.
Okay. I don't like this word Chinese molecules, but anyway, we'll let that go. Right.
Yeah.
Dr. Dr. Venkat, your take on this? These newer IO molecules are supposed to be designed differently. The reason I'm
I have
asking
no
is
experience, not
no
you.
experience. Okay. Okay. Dr. Viraj, you just
Same.
said Salumi 100 mg you have.
Yeah,
So,
same.
okay.
We are
So,
using now these three majoritarily, and we're
okay.
seeing the same spectrum of
Same
IREs.
spectrum. Okay. We have around 30 odd patients now, and again we have seen kind of everything, including pneumonitis. Dr. Senthil, your take on this? They talk of how it is designed differently on a different receptor. So at least for Tislely, they say it's a different binding mechanism. Tori is supposed to have different immune effect. End of the day, does the side effect profile change much?
I
What do
don't think so. I
you
don't
think?
think so.
Well,
So for me,
blood.
the way it is, if it has to work, it has also to produce the problems.
Okay, perfect. So you are the old school that it works if it is causing some problem at least.
That's correct.
Does not
I
make
think that's what the dose has taught us, right?
सेंथिल वामशी ने तुमको ओल्ड बोला?
मैं
It
खुद
doesn't
ओल्ड
matter.
सर मैं खुद बोला कि old people like us believe this way.
Sometimes you like to be called old.
Yeah, but this is, I think, something which all of us would day. And again, as somebody said, the word we should just say newer IOs. I think that's a better way to put it, because we are going to get more and more IOs over time and generic IOs over time. So I think we have around 10 minutes left, Dr. Amish, or 10 minutes. Perfect. So I don't think we should really go. These are what my questions about the rarer IAs, but everyone said cardiotoxicity, it can be absolutely non-dose dependent. It can happen anytime. Myocarditis can happen after the first dose. We know that it happens. Hypophysitis, neurological complaints are there and they are pretty bad. So, instantly, Dr. Viraj, there was a patient of mine who was diagnosed as supposedly having myasthenia. Somebody advised him IVIG also, but it turned out to be some kind of a myositis and it responded to steroid anyways. So, that's a different issue altogether. It responded to steroids, but it was not myasthenia. So, you have to kind of look at these things, and anything that happens you have to worry that it could be at any point of time a kind of a this thing. How do you detect these? I think this is what I wanted to highlight. So, Dr. Safalta, how do you detect or how do you suspect a IRA?
So it's certain things you do regularly, like hypothyroidism for thyroid, you do alternate cycles, and ACTH, you do alternate cycles. But skin rashes, you just see. Otherwise, it is more of a symptom dependent.
Okay. Okay. Dr. Soumya, when do you suspect or how do you detect a IRA?
Yeah, so first though we have to anticipate that, and here are the patients. It's a bit tricky actually to detect IRA. So when it is out of the uh, school books, so sometimes with the abdominal pain, but then you investigate and then you don't find that, and then you have to give empirical steroids sometimes. So when it falls in the as per the adverse event that is mentioned, then it's fine, but it can sometimes also be clinically a little bit difficult to diagnose.
Absolutely. So this is why we are looking at Dr. Dhruv, your take on this because you are giving chemo with immuno in so many cases. A
Yes,
diarrhea
so
could be infected.
many of, yeah. So we are giving chemo with immuno, so that there are a lot of overlapping side effects. So it is
Yeah.
very difficult to say like this is because of chemo or this is because of IRI, immune related. So
Yeah.
I think
Yeah, go
like
ahead.
yeah.
Yeah, go ahead. You are saying something.
Yeah. So, when I am giving with chemo, my first suspicion will be for that side effect maybe because of chemotherapy. As someone said previously, like unusual side effect, definitely I would think of like it is because of immunotherapy. But like common side effects, like suppose say diarrhea, like it is common with chemotherapy. I wouldn't suspect immune-related colitis just from diarrhea.
Correct. I
So
think
like yeah.
end of the day, I think what Sherlock Holmes said, a deductive reasoning and of course hindsight. Hindsight is always 2020, but on that day, it is sometimes difficult to understand whether you're dealing with a chemo-related toxicity, you're dealing with the IO-related, should you jump the gun? So, all these have to be individualized. I think that's the key thing. Yeah.
I recently saw a patient who was like given paclitaxel, carboplatin, and pembrolizumab, and the patient presented first cycle, and patient presented with 3,000 of the platelets. And never seen 3,000 platelets with paclicarbo, so I thought it's like immune related. And I started giving her steroids rather than giving platelets, and next day it jumped. So that's how.
Okay. Could be an immune related ITP as
So
well.
exactly,
Yeah.
Yeah.
exactly same
Yes.
Yes.
Safalta I had in one patient. ANC was 0, but unfortunately, that patient was on pembrolizumab, and we gave high dose steroids, and it recovered.
So again, like I said, it's deductive reasoning sometimes. The only fear we have is when the patient is having symptoms which could be infective. You're always worried that are you increasing the steroid toxicity by giving steroids or not? So I don't think there's anything. So Dr. Senthil, your take on this and just a very pointed question. When should you really start a steroid? Should you first rule out everything else under the sun or rule out the most common and then anyway start steroids empirically? A broad guideline. I know nobody can answer this
I
perfectly.
think I would my threshold to start steroid if the suspicion is there is very low. So I would quickly start on half milligram per kg body weight prednisolone and then start doing all the other workup because we know that it's quite manageable. Even if there is some low grade infection that's going on, this is not going to cause much harm. So if I think that let's say I see hepatitis today and I think it's raised to a level which is worrying, I will start on steroid and then start doing all the other things, send to the gastro and so on and so forth. So I think the threshold should be low in my mind because it can degenerate very quickly and get into trouble.
Absolutely. I think this is basic flow. You should always anticipate, you should detect, treat, and again keep monitoring this thing. How routinely do we assess is a question which many of the people have answered. I think all of us are aware of the problem. We do look at some kind of a system of our own. So I check TSH every 2 to 3 cycles. I know people who do a 2D echo every 2 cycles. I usually do it only if patient is symptomatic. Anyway, the imaging will cover your chest in most cases, so you're okay with the pneumonitis part of it. And these are the generally what we do, and we do ask patients about itching. We do look at their skin. So anything that I have missed, Dr. Soumya, anything beyond this that you would be checking for routinely all patients on a IO?
Everybody has their own way of doing that.
Yeah.
Though the guidelines are a bit more intensive, but probably every 2 to 3 cycles is the one that we look at.
Okay, perfect. I think that's what most of us would be doing.
One area which I have started to see more because I'm testing more is the nephritis, we've started doing this urine. I was not doing this urine routine, and you start seeing that 1 plus protein now. Senthil sir, how often do you see this 1 plus protein?
I see it, Viraj, but the time that I usually see it is most commonly when I'm using it with a TKI, an anti-VEGF TKI. So I find it very difficult to
Correct.
distinguish the
So then
two.
we don't. So that's in
Correct. So
RCC patients.
yes, I mean, let's say endometrial
Everywhere,
cancer,
everywhere.
again, TKI with this. So there are many situations where that happens.
Mm.
So for me,
Yeah.
more than looking at that, if I see that the creatinine is kind of starting to wobble a little bit, then I go chasing it, and then it ends up being a nephritis sometimes. So I
So
think keeping a close watch, and more importantly, the point I forgot to make is that don't let them go out of your eyesight. You know, if you suspect something, ask them to come back in 2 days. Or
that's very, very
if
important.
it's working, very important, you tell them to go and come back after a week, you will find them on a wheelchair or a stretcher, and then that's the end of it.
Yes, I think that is very, very important point you made, especially neurological. As someone said, they can worsen before you know what hit you. And once they hit, and remember the biggest challenge is as far as the thing goes is the neurological around 40% are coexistent with the cardiac comorbidity. So around 40% will have cardiac and neurological together. And once they go on a ventilator with 20% ejection fraction and
Gone.
myasthenia or IVIG or rituximab, infliximab, do whatever you want, they don't come out. Speaking for personal experience, so I can tell you that that happened with one
Agreed,
of
agreed,
the
absolutely.
it's really toxic. So especially for me, this is what it is. You have known knowns, known unknowns, unknown knowns, and unknown unknowns. As we all like to keep saying, remember you should have a plan A, but have a plan B in mind as well. Be alert and be ready to jump the gun and start something more aggressively and bring everybody in. Sometimes it confuses because you bring in a pulmonologist, all they want to do is a BAL. You bring in a neurologist, they'll have to do a NCS first before thinking of anything else. But remember, as a whole, the person orchestrating all these investigations is the oncologist. And the oncologist has to sometimes put his foot down and start a steroid or start antibiotic or start the whatever is needed, not leaving it to other people. So that's another lesson which I think all of us have learned the hard way, that at some point the oncologist has to step in with your own medical knowledge and put your foot down and say, no, this is looking like a steroid. Please give a steroid. Do not wait. Do not let the pulmonologist go chasing the infections, biofires, and etc., trying to find a cause for the pneumonitis. Sometimes it's better to just push it and start your steroids. That's at least my take on it. So other than that, we have discussed the low dose IRAs, which I showed you, and
Vamshi,
discussed almost everything else. Yes, Dr. Amish.
Vamshi, very quickly, people have said that you have 3 minutes more,
Yeah.
but apart from that, 1% of elderly patients on IO, they do die. And this is, series after series they are saying. I've had one death in elderly, but it does not amount to 1%. Just wanted to understand if any of the panelists have seen so many deaths in elderly patients, 65 years and above, what you call elderly. They have seen that 1% because that is what I tell all my patients when I start IO.
Okay. So let me just quickly ask Dr. Senthil's opinion and then maybe Viraj can take it. Dr.
I
Senthil,
haven't
your
seen anything to say that the likelihood of dying is higher with an elderly patient. At least that's not my experience. I don't know the data, but that's not my experience.
Viraj,
Perfect.
your thoughts?
No, it doesn't strike to me. In fact, today I've counseled an 85-year-old HCC to go ahead with IO.
I
It
agree.
didn't strike to me.
I agree with you. I have not honestly seen that much higher incidence. We have seen deaths, again, myasthenias, cardiac, and all, but not specifically geriatric related issues, is what I would say. Last part, anyone tries to predict the IRA by saying, okay, this is a female, this has more comorbidities, this is male, a smoker, obesity, what you were talking about, anything that can predict what causes an IRA from anyone, everyone is shaking their heads. So I think that's
This
the
is
answer.
the unknown part.
This is the
Yes.
unknown.
Surprise.
You know that there might be side
It's a
effects. It's
surprise.
difficult to really, yes, other than probably those patients who have a pre-existing disease, where anyway we would be very careful in starting the IO in the first place. So this is what we are asking with the newer IOs. The answer is no again. Women comorbids, we just don't have a right answer. They have tried everything. They have tried eosinophils. They have tried predictive biomarkers. Dr. Kanu was talking on the chat box about the lymphopenia, and I have learned that lymphopenia is the next big thing for all radiation oncologists, and they're trying to use lymphopenia to predict radiation-induced toxicity. We can have a whole OBTO on that sometime, Dr. Amish, about what lymphopenia is and in radiation how it works. Otherwise, treatment, everybody does it. So this is actually my take-home message, that Side effects can be multiple. Rule out other causes. Do not start steroids immediately, but don't delay too much. Do not underdose. Do not taper too fast. Both of these are very important. Ultimately, a multidisciplinary approach is needed. I think this is the bottom line. Keep calm, expect the unexpected. So, thank you,
Great,
everyone.
great, Vamshi. Great learning
you.
process. Please don't, log out. Parikh sir has the last word on today's OBTO. Sir, over to you.
Thank you very much. Can I have my slides, please? So later this month, I'm going to go to MMC, Madras Medical College, as an exam. And in OBTO, we decided to have at the end something that the postgraduates can take from the exam point of view. So these slides are thanks to Dr. Shruti Goel, and we are indeed very grateful to her. This is a one-slide summary. In the middle, you see the IO molecules. On the left side, you see the study design. On the right side, you see the key findings and the survival graphs. So any postgraduate is interested in, we'll definitely provide this slide to you. Next slide. But if you want to get a gold medal in your exam, then these are the points from this publication that you should remember. IRE incidence overall 56%, within 1 year 40%. Most common in females, younger age patients between the age of 18 and 29, ever smokers, underweight, as well as morbid obese patients. Next slide. What about the correlation with comorbidities? Highest with myocardial infarction and congestive heart failure, also high with renal disease. Interestingly, less in patients with dementia, probably because they don't complain at all. That was just a joke. Next slide. Correlation with the type of cancer, very high with secondary malignancies, breast cancer, and hematological cancer, and less with brain tumors. Next. Organ system, a lot has been discussed, and the percentages are shown here. Type of IRAs on the right side has also been discussed, but these are the specific percentages that you might want to quote in the exam. Next slide. Which ICI regimen has highest risk? And a lot of discussion has gone, and everybody says CTLA is the one which has the highest risk, and that is also there in this publication. Next slide. So if it is given within 30 days of ICI, if chemotherapy is given within 30 days of ICI, associated with reduced IRA risk, and this is statistically significant. Is this due to the immunosuppressive effect of chemotherapy? And the second point is patients developing serious IRAs have 20 times higher risk of death. The hazard ratio, it's 19.28, is just touching the sky. Next slide. IRA and survival outcomes. 70 days in serious IRAs, non-serious IRAs, 89 days. Next slide. And this is to remind you that next month we have an in-person OBTO, that is in New Delhi on 21st and 22nd February 2026. And the one after that will be on Tuesday, 10th March from 7 p.m. on Zoom. So once more, thank you very much for this excellent participation and intense discussion that we had of the real world situation.